Now we'll switch gears and talk about some pancreatic islet cell tumors. So these are neuroendocrine tumors that secrete excess hormones. The treatment for these is usually octreotide or surgical resection. And this should make some intuitive sense to you. We've talked about how somatostatin can just turn off all the hormones. So if you have a neuroendocrine tumor secreting excess hormones, it kind of makes sense logically that somatostatin might be able to turn it off, or octreotide is the drug name of somatostatin. These tumors are associated with MEN syndromes, which we'll talk about as well. This is from our this is from our endocrine pancreas, kind of our pseudophysiology section of this lecture. And what I've mentioned is that we have several different hormones secreted by alpha, beta, delta, and other cell types. And I want to highlight the 5 hormones that we've already talked about, because these are the 5 hormones that are responsible for the main pancreatic islet cell tumors. So let's start with glucagon and the associated glucagonoma. So glucagonoma is an alpha cell tumor causing glucagon overproduction. And first aid has a pretty decent mnemonic. I think glucagonoma is pretty low yield, but when you get tested on it, you're going to be very confused if you don't remember the mnemonic. So I just wanted to throw it out there. You're going to have diabetes, which should make sense. Insulin drops your blood sugar, and glucagon is the opposite. So it's going to increase your blood sugar. You're going to get this dermatitis, and they do like this phrase. If I would remember one thing on this whole slide on glucagonoma, remember this necrolytic migratory erythema. That if you ever see those words, I would highly, highly recommend you pick glucagonoma. You can get diarrhea, declining weight, you can get DVTs and depression. So it's kind of a random mnemonic, and to be honest with you, it's not one that I've spent a lot of time memorizing, but I have been saved a few times by remembering that necrolytic migratory erythema in the setting of glucagonoma. Insulinoma is much more heavily tested because they can test you on the mechanism of beta cell production, insulin secretion, as well as how to differentiate between this versus exogenous insulin use versus sulfonylurea use. So let's go over all that right now. As you probably predicted, an insulinoma is a beta cell tumor that causes insulin overproduction. You're going to get symptoms of hypoglycemia. So you'll have lethargy, syncope, fatigue, tremor, seizures. And this should, again, make sense because insulin drops your blood sugar. So what are you going to find on lab? So you're going to find elevated insulin. You're going to find low blood sugar, as we just discussed. And the important thing is that you're going to find elevated C-peptide. And we'll go over what C-peptide is again. We talked about it in the endocrine pancreas, but I'm going to go over it in great detail. So let's start with the question stem to get this so everybody's on the same page. We have a 34-year-old woman brought to the ED after losing consciousness. Her blood glucose on arrival is 48 and normalizes after receiving IV dextrose. And 48 is low. You don't want it to be that low. Laboratory studies reveal elevated insulin and decreased C-peptide levels. What is the most likely diagnosis? And they'll give you type 1 diabetes. They'll ask you if they're taking a sulfonylurea, insulin. Do they have an insulinoma? Or are they injecting insulin exogenously directly into your bloodstream? So let's go over what is happening in this spot, and then we can answer that question. So we've already gone over this in the endocrine pancreas lecture, but I'll briefly go over it, how insulin is secreted. So we have glucose in our bloodstream. It enters our beta cells. It's converted to ATP, and it'll inhibit this potassium channel. Remember, this potassium channel is trying to pump potassium outside of our cells. By doing that, the outside of our cell would become more positive here as you're losing potassium. Inside would become more negative, and it'd be actually hyperpolarized, so less likely to have an action potential. In the case of glucose and ATP, you're going to have inhibition of this channel. You'll have a ton of potassium coming in. This will cause the cell to depolarize, and it'll cause calcium to enter the cell, and that can help facilitate these release of vesicles into the bloodstream, which contain insulin, which is physiologically great because in times of high sugar like this, you'll have high levels of insulin. So everything's working fantastically. A couple things I want you to think about, though, is that sulfonylureas are a type of drug that can inhibit this potassium channel to facilitate the release. So it'd be the exact same process here. Just like ATP would inhibit this channel, the drug can directly inhibit this channel. Another thing I want you to consider is that C-peptide gets released anytime this beta cell can secrete insulin. C-peptide is released with it. So this right here in this vesicle, there's also C-peptide getting released, and we can measure that in the bloodstream. This can happen in a few different ways. First, it can happen in natural insulin production, like we just talked about, where you have glucose converting to ATP, and then potassium is in your cell, calcium. You have a vesicle releasing everything. So that's perfect. That's one way. Sulfonylureas can also cause this because, as we just discussed, they block the same channel, which will have an increased potassium in your cell. Calcium would get released, release a vesicle, and there you go. You still have this natural beta cell secreting insulin. The third way by which you can have this C-peptide released is when you have an insulinoma, where you have a ton of beta cell release of insulin, but because it's natural, you'll still get the C-peptide. So here's an insulinoma. You'll have a ton of, you might not even need that whole depolarization because the cell's already just producing all these vesicles without any regulation. But because you have all this insulin being released by your beta cells directly, you're also going to have a ton of C-peptide within that. So just to review, in an insulinoma, you're going to have high levels of insulin, as you can see here. You're going to have decreased blood glucose because all the insulin's in your bloodstream, and you're going to have elevated C-peptide. What happens if you're injecting insulin, though? So if you inject insulin directly into your bloodstream, sure, you'll have a ton of insulin in your bloodstream, but your beta cells are not actually producing the vesicles to produce this insulin. So because of that, you're not getting C-peptide in your bloodstream. So you're going to have elevated insulin. You're still going to have decreased blood glucose, but the caveat here is that you're going to have decreased C-peptide because your beta cells aren't producing that insulin directly. And let's go over the third cause. What about a sulfonylurea? So if you're taking a sulfonylurea, it's going to block this. We've talked about this mechanism. And again, you're going to have a ton of C-peptide being released. So you'll have elevated insulin, low blood glucose, and elevated C-peptide levels. Now, these three findings should be familiar to you because they're the exact same three findings as you'll see in a natural insulinoma. So we've talked about how you can differentiate exogenous insulin use from an insulinoma by the C-peptide level. How do we tell the difference between an insulinoma and sulfonylurea use? Well, fortunately, we do have a test called the secretagogue screen, which can detect sulfonylureas in your blood. And so if you have a positive sulfonylurea, a positive secretagogue screen, that means that you have intook sulfonylureas. And if you have an insulinoma, you're going to get a negative secretagogue screen because you don't have any sulfonylureas in your system. So let's go back to our question now. And with the information we just learned, we should be able to answer this. So what's going to happen here is that well, first off, we can rule out type 1 diabetes because type 1 diabetes has the opposite problem. You actually have decreased insulin and hyperglycemia. So we can rule that one out. If we talk about sulfonylurea use, you're going to have elevated insulin. You're going to have elevated C-peptide. And in the question stem, this person has decreased C-peptide levels. And you'll also have a positive secretagogue screen if you need to differentiate this from an insulinoma. So we know that's wrong. How about an insulinoma? What's going to happen here is you'll have elevated insulin, you'll have hypoglycemia, but again, because the insulin is being manufactured within your beta cell directly, you should have an elevated C-peptide. And in this case, this woman has a decreased C-peptide level. So we know that's wrong, and so that makes exogenous insulin use the correct answer here because of the decreased C-peptide level. Let's talk about somatostatinoma. So this is a delta cell tumor causing somatostatin overproduction. We know somatostatin is our stopping hormone, so it turns off all these hormones. So all these hormones here, glucagon, insulin, secretin, gastrin, CCK, GIP, those can all get turned off in a somatostatinoma. So your symptoms are going to be associated with decreased production of each of these hormones. So if you have decreased glucagon or insulin, you can either have glucose intolerance or diabetes. It can be one way or the other, depending on which one gets turned off more. Cholecystokinin is important for gallbladder contraction and the movement of bile through that common bile duct and out into your lumen. So you can get fat malabsorption if you don't have enough bile entering your duodenum. You could also have gallstones start to form as the bile just sits there in the gallbladder. You have a higher risk of forming gallstones. And then gastrin, we know gastrin is our gas pedal for our stomach. It turns on our stomach, it increases the mucosal thickness, it increases hydrogen acid secretion. So if you have decreased gastrin, you're going to have decreased HCl in the stomach or achlorhydria. And you treat this either with surgical resection or you can treat it with octreotide, which is very interesting how this tumor produces excessive somatostatin. And in order to treat that, you can give them somatostatin. I don't know how that works, but I'm just going to take it as fact. Let's move on to gastrinoma. So gastrinoma, also known, which can cause Zollinger-Ellison syndrome, is a gastrin-secreting tumor of either the pancreas or duodenum. How it works is that you have acid hypersecretion because you're producing so much gastrin, and that acid hypersecretion can cause ulcers in your distal duodenum or jejunum. And we've discussed this before in our small intestine lecture. And so let me show you a picture of this. Normally we have, if you have an ulcer in your stomach here, so a gastric ulcer, that's going to be usually caused by either H. pylori or NSAIDs. If you have an ulcer in your proximal duodenum, that's almost always going to be caused by H. pylori. But in this case, if you have a gastrinoma here, it can produce gastrin. This gastrin can stimulate your parietal cells to produce a ton of hydrogen ions. These hydrogen ions can actually make it all the way to your distal duodenum or proximal jejunum because there's just so much to neutralize. And then these hydrogen ions can erode the lining of your intestine here and cause distal duodenal ulcers or proximal jejunal ulcers. Classically, it'll present just like any other duodenal ulcer. It'll give you abdominal pain that improves with meals. And again, this should make some sense. If you have unopposed hydrogen ions throughout your duodenum, that's going to hurt really bad when they reach these ulcers areas, and it's going to cause a lot of inflammation and pain. But if you eat, you can at least have some sort of bicarbonate production that neutralizes most of the acid that reaches the distal duodenum. You can diagnose this by the secretin stimulation test. So normally secretin suppresses gastrin release, but gastrinomas don't listen to that signal. So normally S cells, we've talked about this many times now, they do a few things. They produce pancreatic bicarb for us, or they induce secretion of pancreatic bicarb. And they also decrease gastric acid secretion. And the problem is that in gastrinomas, even if you have this large gastrinoma that's hypersecreting these hydrogen ions into your gastric lumen, even if you have secretin being produced, the gastrinoma doesn't listen and it just keeps producing all these hydrogen ions. And so how to test this is you would give somebody secretin and you'd see if their gastrin levels go down, which in this case, they would still stay elevated. So our last tumor we need to talk about, our last islet cell tumor, is a VIPoma. And so a VIPoma is an overproduction of VIP. It presents with watery diarrhea and vomiting. And the classic mnemonic that you've probably heard before is this WDHA syndrome. And that stands for watery diarrhea, hypokalemia, and achlorhydria. And so I tried to break it down here. So this watery diarrhea is obviously here. And why is it called the hypokalemia and the achlorhydria are a consequence of the vomiting that happens. We talked about this in our stomach lecture. It's not too uncommon for other conditions, like bulimia will also present with a hypokalemic, hypochloremic metabolic alkalosis. So Let's talk about why that is. Hypokalemia is caused by all this, as you're losing so much volume through vomiting and through diarrhea in the case of VIPoma, you're losing so much volume, your kidneys start to panic and they say, we need to keep volume at all costs. And what they'll do is that they'll retain sodium because they know that the more sodium in your bloodstream, that'll cause water to stay in the bloodstream with it. The problem is that for every sodium ion that you reabsorb into your bloodstream, you have to excrete a potassium, so you become hypokalemic. Achlorhydria should make sense. As you're vomiting out all this HCl into your lumen and outside of your GI tract, you're going to lose a lot of this chloride here. That's the mnemonic that you're going to be tested, that almost all resources mention, this WDHA syndrome, which is helpful in some capacity. What I like to do though, because it's kind of coming out of both ends, I always remember VIPoma as very important potty syndrome. That's what, because you really, if you're having diarrhea and you're vomiting, then the most important thing in your life is a bathroom, right? So this helps me because then I just remember that, okay, I know it's diarrhea and I know it's vomiting, and as we've discussed previously, anybody who has significant vomiting will always have that hypokalemia, the achlorhydria, and you'll have a metabolic alkalosis. So that's not specific to VIPoma necessarily. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.